Hello everyone. So the topic of my today's presentation is corners of the knee and why there is so much concern about these structures. So we will go through the stuff. So everyone talks about the cruciate ligament and the menisci, but what we are going to talk about is some other structures. Like on medial side, we have medial collateral ligament. Then we have the lateral collateral ligament, biceps femoris tendon attachment, popliteus tendon and muscles, popliteofibular ligament. We have arcuate ligament. We have posterior oblique ligament, and we have medial patellofemoral ligament. So we will talk about these structures, their imaging appearance, and how they appear when there is injury. So the goal of today's presentation is to know the normal anatomy of these structures, what are the importance of these structures we should know, and what is the imaging appearance when there is any tear, and what are the treatment options. So before going further, let's just go through this question. A patient was diagnosed with complete ACL tear, missing an injury to structure X can result in ACL graft failure. So what is this structure X? Is it horizontal meniscal tear with parameniscal cyst? Is it grade 2 meniscal tear? Is it Pacensor and bursitis, or it is fibular stellate process avulsion? So think in your mind and read the question carefully. So the answer is fibular stellate process avulsion, because it can lead to rupture of the posterolateral corner structures, which are very important, and if they are ignored, ACL graft can undergo failure. So we'll see the medial structures first. So this is the axial graphic at the level of medial femoral condyle. So this is medial femoral condyle. This is medial collateral ligament. This is medial retinaculum. This is posterior oblique ligament. This is medial of gastrocnemius. This is semimembranosus, semitendinosus, gracilis, and sartorius. This is axial section at the level of joint, where we can see the medial meniscus, the medial collateral ligament, the semimembranosus tendon attachment. This is medial of gastrocnemius, and these are pes tendons. This is the axial section at the level of proximal tibia, where we can see attachment of semimembranosus tendon and pes inserine tendons. This is the lateral view of the knee joint, where we can see patella, superficial medial collateral ligament, pes tendons, semimembranosus, medial of gastrocnemius. This is the coronal view of the medial collateral ligament, where we can see different layers of MCL. So superficial most is the crural fascia. Then we have superficial medial collateral ligament. Then we have the deep medial collateral ligament, which is formed by meniscofemoral and meniscotibial attachments. So this is the superficial medial collateral ligament, and deep to it is the deep medial collateral ligament. Slightly posterior to the medial collateral ligament, we can see the posterior oblique ligament, which is another important structure. So this is coronal MRI, slightly posterior to the medial collateral ligament, where we can see the posterior oblique ligament. So here we can see this is the posterior oblique ligament. This is the patellofemoral ligament, medial patellofemoral ligament, and this is the lateral view, where we can see this is the medial patellofemoral ligament, and this is the adductor magnus tendon. They attach at the site of adductor tubercle. This is superficial medial collateral ligament, and these are pes tendons. So again, here we can see this is the medial collateral ligament, and this is the medial patellofemoral ligament. Here you can see this is the medial patellofemoral ligament. This is the sagittal MRI image, which is showing junction of the posterior horn of medial meniscus with the capsule. So if there is injury in this area, it will appear hyperintense, and this is known as ramp lesion. There is often associated marrow edema in the posteromedial tibial plateau. So this is ramp lesion. Let's see the normal MR anatomy. These are axial section. This is femur. This is vastus medialis obliquus. semimembranosus, tendinosus, gracilis, and sartorius. So as we are moving caudally, we can see this is medial head of gastrocnemius, which has started appearing. Here we can see this is semimembranosus, this is medial of gastrocnemius, and this is the interface between these two tendons where sometimes we see Baker's cyst. This is semitendinosus, gracilis, and sartorius. This is medial collateral ligament, and this is the posterior oblique ligament, and this is the medial retinaculum and medial patellofemoral ligament. As we are moving down, we can see attachment of semimembranosus over the tibia, and pes tendons, they are moving anteriorly over their attachment on the anteromedial aspect of tibia. On coronal view, we can see this is medial collateral ligament. Going slightly posteriorly, we can see posterior oblique ligament. These are the head of gastrocnemius. This is semimembranosus. This is the interface between these two tendons, where we often see Baker's cyst. On sagittal view, you can see the region of ramp area where there is juncture between the posterior horn of medial meniscus and the capsule. So if there is injury in this area, it will appear as hyperintense, which is known as a ramp lesion. It is arthroscopic blind spot, and it is important to report that on MRI. This is semimembranosus tendon, and this is medial of gastrocnemius. So medial supporting structures include static medial stabilizers, which include superficial medial collateral ligament, posterior oblique ligament, and deep capsular structures, which are meniscofemoral and meniscotibial ligaments. Whereas dynamic support is provided by the surrounding muscles. The important one are semimembranosus and vastus medialis. So MRI grading of MCL injury is basically classified in 3 grades, and they're best assessed on coronal plane. So in grade 1, you will find some amount of edema superficial to the medial collateral ligament. So here we can see slight edema, hyperintensity on the PDFS sequence, superficial to the medial collateral ligament. So this is grade 1 MCL sprain. Again, we can see this is medial collateral ligament, and there is edema superficial to the medial collateral ligament. So this is grade 1 MCL sprain. In grade 2 MCL sprain, there will be slight laxity, and there will be hyperintensity or edema surrounding the medial collateral ligament. So here we can see this is grade 2 medial collateral ligament injury. Again, we can see there is grade 2 medial collateral ligament injury in the femoral attachment side. This is the axial section showing same grade 2 medial collateral ligament injury. Again, we can see grade 2 medial collateral ligament injury at the site of femoral and tibial attachments. In grade 3 medial collateral ligament injury, there will be complete detachment of the medial collateral ligament from the femoral condyle. So here we can see this is the medial collateral ligament, and it is completely gone from the its bone attachment. So here again we can see there is grade 3 medial collateral ligament injury at the femoral attachment side, also seen on axial view. In grade 3 medial collateral ligament injury, there is edema surrounding the tendon, and there is laxity. Again, here we can see there is grade 3 medial collateral ligament injury. Often we can see avulsion fracture from the medial collateral ligament attachment side. Like in this case, we can see there is avulsion fracture from the femoral condyle. This is the image showing pes inserine bursitis, which is basically bursal distension in relation to the pes inserine tendons. And it appears similar to the feet of this pes inserine. We can also see calcification at the femoral attachment site of medial collateral ligament, and this is known as Pellegrini's Stida lesion. Identify the abnormality, whether there is tibial spine avulsion, whether there is patellar fracture, where there is a second fracture, or there is reverse second fracture. So what do you see in this case? So in this case, we see reverse Segon fracture. You can see there is fracture fragment adjacent to the medial tibial plateau, which is reverse Segon fracture. Segon fracture is seen on the lateral side, whereas reverse Segon fracture is seen on the medial side, and it is associated with posterior cruciate ligament injury. So MCL tears are managed non-operatively or conservatively, and if there is combined MCL and ACL injury, surgeons often go for a ACL repair and leave the medial collateral ligament as such. Let's move to the lateral side. So on lateral side, we can see the lateral retinaculum, iliotibial tract, lateral collateral ligament, biceps femoris tendon attachment. Slightly distally, we can see the popliteus tendon, lateral collateral ligament, again iliotibial tract, biceps femoris tendon attachment. You can also see lateral meniscus over here, and this is the popliteus tendon. This is the lateral view, which is showing the lateral collateral ligament and popliteus tendon. And we can also see popliteofibular ligament, which is a ligamentous attachment from the popliteus tendon to the head of fibula. Again, we can see, so this is the head of fibula, and we can see important structures attaching over there. So what are these structures? First, we have popliteus tendon or muscle, and we have arcuate ligament. There's popliteofibular ligament. Then we have lateral collateral and biceps femoris tendon attachment. So this is the superior view of the fibula, where we can see attachment of the lateral collateral ligament and biceps femoris. And over the styloid process, we can see attachment of popliteofibular ligament and arcuate ligament. So here we can see close relationship between the popliteus tendon and the lateral meniscus, and we can also see how the popliteomeniscal fascicles look like. So this is the MRI image where we can see lateral horn of lateral meniscus, posterior horn of lateral meniscus, popliteus tendon, and the popliteomeniscal fascicles. Again, we can see popliteus tendon here, and the structure superficial to the popliteus tendon is the arcuate ligament. And in this coronal image, again, we can see arcuate ligament overlying the popliteal tendon. In this axial image, we can see this is fibula, which is a sesamoid bone posterior to the lateral femoral condyle. And here we can see this is fibular ligament. So it attaches the fibula with the head of fibula. Here again, we can see fibular ligament. So this is fibula, this is fibula, and this is fibular ligament. So there is inverse relationship between the arcuate ligament and fibular ligament. So if this fibula is present, the sesamoid bone is present. So fibular ligament will be prominent and arcuate ligament will be rudimentary. Let's see this graphic, which is showing another important structure on the lateral aspect, that is iliotibial band or iliotibial tract, which attaches over the Gerdy's tubercle. So here we can see the iliotibial tract, which is attaching over the Gerdy's tubercle. So in runners and cyclists and persons involved in athletic activities, they can have friction between the iliotibial tract and lateral femoral condyle, which is known as runner's knee. Let's see the axial MRI. So this is the iliotibial tract. This is biceps femoris. As we are moving down, we can see the lateral collateral ligament, and also this is the popliteus tendon. And we can say this is popliteus tendon. This is iliotibial tract. This is lateral collateral ligament. This is biceps femoris. And we can see lateral collateral ligament and biceps femoris. They're attaching over the head of fibula. On coronal view, again, we can see this is iliotibial tract, which is attaching over the Gerdy's tubercle. This is anterolateral ligament, which is another important structure on the lateral side. We have popliteus tendon here. Again, we can see slightly posteriorly, this is lateral meniscus, popliteus tendon, which lie in close relationship with the lateral meniscus. We have lateral collateral ligament, and we have biceps femoris tendon. We can see popliteofibular and arcuate ligament also here. On sagittal view, also you can see This is the lateral meniscus. And you can also see the popliteus tendon and popliteomeniscal fascicles. This is head of fibula. And this is the biceps femoris tendon attachment over the head of fibula. So injury or disruption of LCL is less common than injury to MCL, and it is often seen in conjunction with either an ACL or PCL injury. So we can see either partial tear with laxity, or we can see distal LCL osseous avulsion, or we can see complete rupture from the middle part of lateral collateral ligament. So here we can see there is osseous avulsion from the head of fibula, and the lateral collateral ligament and biceps femoris, they are gone from their bony attachment side, distal bony attachment side. And there is a lot of edema over here. Here we can see there is arcuate ligament rupture, which lie over the posterior to the popliteus tendon and muscles. So here we can see popliteus tendon and muscles and edema superficial to them, which is because of arcuate ligament injury. Here we can see there is rupture of iliotibial tract over here by popliteus tendon is also gone. Again, on coronal section, we can see rupture of iliotibial tract. Now identify the abnormality here. Whether there is arcuate fracture, reverse Sagan fracture, or tibial spine fracture. What do you find here? The answer is there is Sagan fracture. Another close mimic is this, which is fracture from the stellate process of fibula, which is arcuate fracture. So it is important to identify the radiograph and differentiate between these two abnormalities. So Sagan fracture is basically fracture from the lateral aspect of tibial plateau, and arcuate fracture is fracture from the stellate process of fibula. So what is the mechanism of Sagan fracture? Sagan fracture is basically because of avulsion fracture of anterolateral ligament. So anterolateral ligament is formed by the posterior fibers of iliotibial tract and anterior fibers of the lateral collateral ligament. So here we can see there is a Sagan fracture over here because of rupture of anterolateral ligament. Again, we can see here, this is the anterolateral ligament, which is attaching over the lateral tibia. Here again, we can see there is a fracture of the lateral tibial aspect, and this is Sagan fracture, which is because of rupture of avulsion fracture from the anterolateral ligament. The axial view again showing the same thing. So surgical repair of lateral collateral ligament is necessary when it is associated with acute ACL injuries. And result of surgical reconstruction is good in acute cases, whereas it is poor in cases of chronic instability. And the sensitivity of MRI greatly reduces with time. So if we are able to diagnose it in the acute phase, so it can be repaired and the patient can be saved from ending up in chronic posterolateral instability. And the sensitivity of MRI greatly reduces with time. So take-home points are, we should know the normal anatomy, and we should know the MRI appearance of tear with grades. We should know that MCL injuries are often managed conservatively, and PCL injury, it is important to identify. Early detection is important, and if we are not able to identify them, patient undergoes ACL repair, so the graft can fail. So that's all from my side. Thank you so much.